just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting, and I consented on behalf of Palmetto GBA. I will now introduce the speakers one at a time. I would like to remind the speakers to please keep your presentation to 15 minutes at most so that all the speakers may present. Our first speaker is Dr. David Kennedy, speaking about epidural procedures for pain management on behalf of Vanderbilt University. Dr. Kennedy.
Thank you so very much. I'm honored to be here, and I really want to thank everyone's work in this, from the expert panels to staff time, et cetera. This is a very challenging topic, and I commend everyone for their outstanding work today. My name is DJ Kennedy, and I am presenting on behalf of the Spine Intervention Society. I do work at Vanderbilt University Medical Center, where I'm professor and chair of the Department of PM&R, and an active clinician who does injections. And that is probably my biggest disclosure, that I actually do these as part of my living. I have no relevant disclosures otherwise. I know you all have this slide deck from which I'll be presenting. We'll also present to you formal written comments before the deadline. But to going through covered indications, the first one, number one, imaging to support radiculopathy. I suggest changing to radicular pain rather than radiculopathy. Many patients can have severe radicular pain in the absence of a classic radiculopathy, which by definition is a reflex change, a motor deficit, or a sensation deficit. And neurological deficits themselves are not necessarily an indication to support radicular pain. Tests like straight leg raise is a specific test for radicular pain, but not very sensitive, thus it is often not present. Most important, patients with radicular pain who do not have a positive straight leg raise or neurologic deficits are just as likely to respond to epidural injections as those who do not. In fact, most of the studies showing positive response enrolled people with radicular pain rather than frank radiculopathy, if you truly read what their inclusion criteria were. So we suggest rewarding to, say, history and/or physical examination, diagnostic imaging supporting one of the following: lumbar, cervical, thoracic, radicular pain. At a previous one of these events, additional comments were made about removing the word central from disc herniations, which I would concur with, because there's no difference between a central and a paracentral disc herniation in terms of epidural outcomes in the literature, and adding spondylolisthesis, which would also be appropriate. Number one, requirement of 4 weeks duration of pain. While I agree this is actually common practice for many, for people with acute severe radicular pain from a herniated disc, waiting to delay an epidural steroid injection, which does have some of the higher level of evidence for it, is tricky. So simply suggest rewording to the following: pain duration of at least 4 weeks, with the exception made for severe radicular pain where a 4-week delay cannot be tolerated. These are in patients that can't tolerate physical therapy, are not doing well with meds, or putting them on meds is not a great option. And it's not the majority of patients, but there is a number of patients that are in severe pain that waiting this long for an effective treatment is not ideal. Covered indications, number two, requirement to use contrast. We fully support the use of contrast. I think it's essential as a safety mechanism and as a therapeutic to make sure the medication is going to the right place. However, there are people with documented contrast allergies, and although not necessarily in this population, as insurers follow it, pregnant patients would also be a contraindication to fluoroscopic or CT guidance. So simply suggest rewording the following: ESIs must be performed under CT or fluoroscopic guidance with contrast unless the patient has a documented contrast allergy or pregnancy, at which time ultrasound guidance without contrast may be considered in these and similar circumstances. We all know ultrasound guidance does lack compared to fluoroscopy or CT's guidance, so we're not hoping that it is standard. But in these limited restrictions, I think it's reasonable to consider it. A repeat injection is another big point. That it says after an initial injection, the patient's pain returns prior to 3 months. It is reasonable to reinstate relief with a repeat injection. So if we require a 3-month threshold, there's a significant number of people who would otherwise obtain relief from a second injection that will proceed to surgery in that interim. And there are people that are managed with epidurals. It's not many in my practice. However, there are people, as we talked about before, that have this acute, subacute pain that you're trying to get over or through the disease process with 1 or 2 injections, and they may be spaced a couple of weeks apart coming through. I think that's a better way of doing this when we're trying to get somebody over that acute pain instead of saying, well, we're going to manage this with every 3-month injections. So it suggests rewording to the following. Repeat ESIs are appropriate. 1 to 2 prior ESIs provided prolonged radicular pain, 50% for 3 months for the condition being treated. ESI should not be repeated within 14 days. If a patient fails to respond to a single ESI, a repeat ESI after 14 days can be performed using a different approach and/or medication, with the rationale and medical necessity for the second ESI being documented in the medical record. We also know that people respond to different medications differently. The same is true with NSAIDs. Some people respond to ibuprofen and others respond to meloxicam differently. So it makes sense that we can try different medications or different routes and approaches in hopes of avoiding a more costly surgery. The injected, number 6, is steroid. If the injections don't include steroids, then they're not really epidural steroid injections. So we suggest replacing ESI injectant with epidural injectate. The current wording is confusing and stipulates that anti-inflammatories are required, and it says plus or minus contrast, so it might be implied that contrast does not, but anti-inflammatories are. So suggest rewording. The epidural injectate must include contrast agent unless the patient has a contraindication contrast. Injectate may also include corticosteroids, local anesthetic, saline, and/or anti-inflammatories. Although the anti-inflammatories, aside from the corticosteroids, I'm not aware of anybody really injecting those. Most people are injecting corticosteroids or local anesthetics and saline. Number 7, requirement of other conservative treatment. And I say this as a rehab doctor who does a lot of conservative treatment and tries to avoid both injections and surgery for my patients. It says, but while some patients benefit from the multimodal treatment, there are plenty of people that experience relief from an epidural and may not require other conservative treatment. So suggest rewording to indicate that ESIs may be performed in conjunction with other conservative treatments. Requiring it may just be requiring unnecessary treatment when it's not needed. And the data on this comes from chronic pain conditions and very different patient populations in the Medicare population. So hopefully, you can treat someone with the least amount of treatment that is effective in offering long-term response. We do recommend a new indication for diagnostic spinal nerve block, suggest including the following. Diagnostic spinal nerve blocks are performed by injecting anesthetics onto a single nerve to help confirm or rule out the source of the patient's pain, often to assist in surgical planning. These blocks utilize the same CPT codes as transforaminal epidural steroids and should be allowed in patients that have failed a therapeutic ESI when the medical necessity is documented in the records. The most common place for this for me is somebody that is going to get an L5-S1 surgery, and the surgeon wants me to inject L4-5 because they have some radiographic abnormalities there. And if they don't get some relief with it, then they usually will avoid doing the second-level surgery. And there's no steroid or no anticipated therapeutic benefit from it. The goal of it is purely operative planning. And this does play into a little bit of our recommendation for numbers of injections later. Limitations, number 1, injections performed without image guidance or by ultrasound. Again, suggest allowing for ultrasound guidance in patients with documented contrast allergies, pregnancy. Number 6, limit 4 ASIs to 12 months. As I mentioned before, diagnostic selective nerve root blocks, which can be used for surgical planning and have the same codes. We really suggest considering the allowance of 3 ESIs for 6 months and 6 for 12 months, regardless of the number of levels involved. And this would be a rare case from a therapeutic standpoint, but occasionally needed from a planning perspective, meaning the number of people that are going to need 6 ESIs in 12 months in my own clinical practice from a therapeutic standpoint is almost none. Limitations, number 11, a series of epidurals. While we do not support a series of 3, and even in the slightest, we do support repeat injections if previous injections were successful in achieving pain relief and functional improvement, or only one prior injection was unsuccessful and, again, something was changed. So suggest rewording as follows. It is not medically reasonable or necessary to prescribe a predetermined series of epidurals. The predetermined is where people go awry with this, I think. Number 12, limitations in steroid dose. The dosages recommended are quite bluntly inaccurate. Data from studies looking at doses implemented in transfemoral injections have been inappropriately extrapolated here to interlaminars. Suggest rewarding the following to allow for a slightly higher dosage, consistent with the previous version of the LCD. Steroid dosing should be the lowest effective amount, not to exceed 80 milligrams of triamcinolone, 80 milligrams of methylprednisolone, 12 milligrams of betamethasone, or 15 milligrams of dexamethasone per session. This is consistent with the best literature on the topic, and it is consistent with practice patterns and local environments that I have seen around the nation. Number 13 in limitations, treatment exceeding 12 months. This is a tough one. It is a little challenging given natural history. If you inject someone and then they're better for 12 months or 15 months and they come back with a recurrence of the same pathology, are you now treating them beyond 12 months or not? There are clearly people that are trying to avoid surgery and, they are treating beyond 12 months. And the requirement to communicate with a primary care provider to discuss whether the patient is eligible really is challenging in a lot of ways. Many people do not have a primary care doctor, and I do expect the injecting physician who is injecting steroids generally in the epidural space to be a source of knowledge and a high source of knowledge as to is that appropriate for a patient and coming through. Obviously, communication is ideal, but to require this in the setting is really different than any other areas we're going through in medicine where we're expecting the specialist to coordinate with the primary care doctor, which doesn't always happen. Lastly, provider qualifications. Consider replacing healthcare professionals with physicians. Physicians do have the prerequisite training to accurately select patients, safely perform technically demanding procedures, immediately recognize, evaluate, and address potentially serious life-altering complications. My whole career has been on the safety and efficacy of spine injections has been the main focus of mine. I've published over 100 articles on this, and these injections do have real risks. They can paralyze people. They can cause all kinds of problems, and we clearly do not have an access issue. Given the number of injections done nationally, that there's not an access issue, and we should require and demand the highest level training possible for our patients. If we recommend adding the following language, patient safety and quality of care mandate the healthcare professionals who perform epidural injections procedures for chronic pain, not surgical anesthesia, are appropriately trained by an accredited allopathic or osteopathic medical residency and fellowship program in an ABMS or AOA accredited specialty whose core curriculum includes the performance and management of the procedures addressed in this policy. If the practitioner works in a hospital facility at any time or is credentialed by a hospital for any procedure, the practitioner must be credentialed to perform the same procedure in the outpatient setting. At a minimum, training must cover and develop an understanding of anatomy and drug pharmacodynamics and pharmacokinetics, as well as proficiency in diagnosis, management of chronic pain-related disease, the technical performance of the procedure, and utilization of required associated imaging modalities. Again, someone that has 2 years of post-undergrad training with no subspecialization cannot replace somebody who's gone through medical school combined with residency and generally a fellowship. Please, society guidance. The North American Spine Society revised their coverage policy recommendations in 2020, and these should be reviewed and ideally replace the 2013 and 2011 references on pages 25 and 26. And there were typos in the following society names: American Society of Anesthesiologists, American Association of Neurologic Surgeons, and Congress of Neurologic Surgeons, and Spine Intervention Society. Thank you all for your time, and I hope you all have a wonderful day, and I appreciate the ability to present this.
Thank you, Dr. Kennedy, for your presentation. Our next presenter is Dr. Robert Wilson, speaking about epidural procedures for pain management on behalf of the Pain Society of the Carolinas. Dr. Wilson does not have a PowerPoint presentation, so we will cede the floor over to Dr. Wilson.
Thank you. I appreciate the opportunity to speak here today. Again, Robert Wilson. I do represent the Pain Society of the Carolinas. I'm president of that society. It encompasses about 1,000 members, mostly in North and South Carolina, but also surrounding states as well. My background is anesthesiology and interventional pain management, and I have board certification in both those fields. I'm a private practice physician calling you from Salisbury, North Carolina, and I, again, am practicing as a city of about 40,000 people, and the only board-certified pain doctor in this community. I was glad that Dr. Kennedy spoke first. I've been reviewing his letter, his information that he just went through, and if I had to set and type out a letter that would cover all the points that I would like to cover, it would be that letter, that information that he told the committee today. I would just add some personal comments about it. The thing that I see in my clinic every day are people who come in and they will, he alluded to it, but said that some people call and they'll have acute pain that's just started a day or two before, try and get in the clinic, go to their primary care, gets in here, and it hasn't been 4 weeks, and they can't go to physical therapy. They can't even lay in an MRI machine to go and get a study done to see exactly what's going on. But purely by history and physical examination, it appears to be a radicular pain problem. So it does occur. We have other patients that come in our clinic, and we ask them how long they've been having pain. They'll say, well, it's been going on for 6 months, just now getting worse, and to the point where it's just not going to go away. I've tried everything else, and then we go and move forward with it. But I do agree with the point of the requirement of 4 weeks. There needs to be some verbiage in there, the way it's written by him. I agree, some exceptions where the acute pain is there, where they can't go through physical therapy, et cetera, that we would be able to move forward with that and not be stuck on requiring 4 weeks. The contrast, agree. I use contrast in virtually every one of my patients, unless they have a documented allergy to it. I do agree with it, but there are circumstances that do come up, whether it be allergy or pregnancy, like he stated, and I agree that we could have some give that way as well. Repeat injections, the one thing that I read when I read through the proposed LCD is, I'll give you my scenario when I see a pain patient that comes in for lumbar radicular pain. They will come to me, getting worked up, MRIs done, et cetera. They tried over-the-counter medications, maybe some prescriptive things from their primary care or their surgeon. They're sent to me for a diagnostic or a therapeutic block. When we do that procedure, it is a rare event that one injection will take care of it, whether it's an interlaminar epidural steroid injection or a transforaminal block. When I do my first procedure on that patient, I generally will schedule them routinely to come back at 3 or 4 weeks and schedule a second procedure. And I tell my patients, I said, my hope is that you will come back and you will feel improved from this and not have any more pain. But when they do come back, the majority of them are better, 20, 50, 70% better maybe, or they felt better for the first week or two, and then the pain has returned 3 or 4 weeks later. Maybe improved over baseline, but still there, causing significant pain, and we go ahead and do the second one. I said, when they do come back to me, the 1 out of 50 or so that do come back to me, who say, I really don't hurt at 3 and 4 weeks. They have no pain. I certainly said, this is great information. We don't want to move forward and do a second one. It's a waste of steroid. You don't need it in your body if it's not going to be working on anything, doing anything good. But I tell them we'll make an appointment a month later. If you're doing well at that time, you can simply call and cancel. But to do one injection, have a guideline that says 3 months before you can do another one, it would change course of how I treat my patients, my Medicare patients in particular. It is a restriction that I just don't know that how I would have to handle it. One thing I worry about in this setting, if this were the LCD would be enacted, we've been battling an opioid crisis now for some 5 years or so. Those in my line of work, when I was trained 21 years ago, we used to write a lot more opioids than we do now. I've leaned more on doing procedures now than I've ever done before because we just simply don't write near as much opioid as we used to. I'm concerned about this when I see restrictions that would be placed on the amount of medications that we use, on the frequency of epidural steroid injections, limiting it to 4 a year. I'm just concerned that people are going to be needing some other type of care. What I don't want to do is reinitiate more opioids, especially in the elderly. So it's a concern of mine. The other concern I have, if this were to become enacted the way it's written, is that we would find more patients who are going to be strongly considered for surgery. I don't know if that is the right avenue. Some of these patients I take care of who are in their 80s, just simply don't have, they've got other comorbidities, and they're going to be candidates for an operation, especially anything of any magnitude. So I think that in the efforts of trying to maybe curtail some of these injections that we do every day, Dr. Kennedy, people like myself, we depend on the ability to have this in our bag of tricks to use on these patients to avoid that. If we go on to say beyond the, have to wait 3 months to do the second one, the limit of 4 a year, what I routinely do with so many of my patients is I'll do one 3 or 4 weeks later, and then we'll follow up with them. Generally, by that time, they're 75 to 90% improved. We'll see them back in about 3 months, and it is a rare exception in these chronic degenerative lumbar spines that we see in the elderly population that around that time frame, they may start having pain again. And so we'll routinely do another epidural at 3 months, and I see a real pattern in practice in patients who get these therapeutic injections. If we have a limit to 4 in a year's time, if I do one a month later, and then every 3 months thereafter within a 12-month period, that alone is 5 in a year. And I, like Dr. Kennedy mentioned, I think those of us who practice interventional pain medicine in a responsible manner, I don't line up a series of epidurals. I do line up a second epidural because I see it day in, day out in my practice. Where we need to have that epidural done most of the time. But again, we don't do it if we don't need to. We certainly are physicians that practice medicine in a way that just to have a recipe cookbook for it. But at the same time, it's patterned somewhat by what we see day in, day out. I do agree also the wording of the ESI injectate versus the epidural injectate. Most times when we do our injections, we use it with or without local anesthetic in the epidural space, but generally it's with a steroid solution, but we do have patients who are sent to me by physicians who want simply a local anesthetic block to find out. So the change of wording on that would be something that would probably be beneficial. I deal with this with insurance companies too, in that they have come down with the idea of doing physical therapy first and other conservative care. And believe me, when I say that I'm all in favor of that, but generally by the time they get to a clinic like mine, they've been through all the things that they can tolerate. And by that I mean doing physical therapy first is sometimes accomplished. A lot of times by the time they come here, that has been tried, and because of the pain they have, acute radicular pain, they have had to stop it. And so I think using it along with injection therapy, medications, etc., is more appropriate way. However, the wording should be put to reflect that. I know that one insurance company I deal with now simply makes them hold out for that, and a lot of times the patients are just miserable to actually get here. So it's my belief that if you can do an epidural injection or two and get someone doing better, getting on a home exercise routine, I feel a lot of times the physical therapy is pushed so much up front that our interventions are so effective that they can be taught at a time when they're not in, they do a lot better, etc. So I agree to have that performed in conjunction with other conservative care. I have touched on the other points here, the limitations, number 6, about 6 in a year's time. I do have one lady in my practice, I'll make a personal note about that. I was doing her injections every 3 months, and she would come to me and she'd say, "Doc," she said, "it's 6 weeks. I just can't get out of bed. I can't do my laundry. I can't make my meals, etc., etc." And so given the current guidelines doing 6 a year, it's rarer, but I have one lady in my practice that I do that with, and that keeps her off of all of her opioids. It keeps her more active and functional in her house. So it goes back to the point we'd like to make that 4 in a year's time can be too restrictive in a lot of cases. And a lot of my cases, for example, as I mentioned earlier, at the same time, I don't abuse the privilege. I try and tell patients we do inject you with steroid medication, especially if they're diabetic, etc. We try to use as little as we can with each injection and do as few of them as we can, but we have to do it at the same time to improve their function, and I hate to be restricted with that. The point I also want to make, and the very last point here about the provider qualifications, my background before I went to medical school, I was a nurse anesthetist. And I see across the country, I see in this region here where mid-level providers, advanced practice providers are trying to get privileges to do things like pain medicine like we're talking about here today. And I can talk from a personal standpoint that in my training as an undergraduate nursing degree and degree in nurse anesthesia, I had no real ability to help those differentially diagnose and treat conditions. I certainly wasn't trained in the anatomy and physiology that I got in medical school. I know it's kind of a sticking point these days when I speak to this topic, but the reality is if we're trying to limit the amount of potential harm that can be done, the amount of epidurals that would be done in non-qualified hands, I think the wording that Dr. Kennedy spoke of, where you are trained in an accredited allopathic or osteopathic medical residency or fellowship program, like I went through, it is something that I think will be better served to the Medicare patient population if we do that. I think if we open the doors and let other lesser trained non-physician providers to provide this care, I am concerned about the safety to the patients, quite honestly, and concerned about sham procedures that don't really get performed in a qualified manner, et cetera. I think we need to, it's time that we, if we can, word this in a way that will allow the physicians to be the personnel to perform these procedures simply based on my background, my experience that I can attest to, but also knowing how nurse anesthetists are well trained for what they're trained to do, administering anesthesia in operating room setting. But even with their additional training programs that they have, I don't know much about it. Who monitors that? If there's an overseeing organization outside of the American Association of Nurse Anesthetists that oversees it, it would be to our best for our patient population if we were to curtail that activity. So that concludes all that I have to say. I appreciate the opportunity to speak here today. Again, I hope that we can come to common ground on the way the wording is now and what we see in daily practice. What I see here certainly, because if it stands the way it is proposed, I have concerns that it'll change the course of how my patients are taken care of, going on to surgery quicker, et cetera, having more advanced minimally invasive surgeries in my hands, et cetera, when they could just easily get by with this more conservative interventional therapies that I perform on. I thank you all for your time and attention.
Thank you, Dr. Wilson. Does anybody have any comments or questions? All right, then. Given that, then thank you all for coming and participating in the open meeting for JJ, and this will conclude our meeting. Thank you.